Okay. Good afternoon, everyone. My name's Kenny Fraser. I'm the CEO of Triscribe. Triscribe is developing analytics based on hospital e-prescribing systems. We work with hospital e-prescribing systems, and our software helps hospital pharmacists optimize medicines usage. It helps hospital pharmacists improve medicine safety, and it also helps hospital pharmacists reduce the admin and reporting burden so that they can focus on the real clinical work that adds value in the way that they do. So I'm here today with Slee. Anne is one of the leading digital pharmacy and most respected digital pharmacy authorities in the UK. She also happens to be a co-founder of Triscribe. So Anne, can we start? You founded Triscribe with Aziz Sheikh and Colin Simpson from the University of Edinburgh. What motivated you to found Triscribe?
I think the three of us have all worked in the area of electronic prescribing for a number of years, looking at evaluating systems and understanding the benefits that they can bring. What's become very apparent over the last few years is that getting the information out of these systems and using it to improve patient care has been a challenge and has not been something that's easily done. And what we wanted to do was to help people to do that so we can really truly realise the benefits of these systems.
Okay, brilliant. Sounds great. So maybe it's worth taking a step back for people just for some context. So yeah, e-prescribing, surely every hospital does prescribing electronically and it's all pretty established, or not?
No, the rollout of electronic prescribing in England's been very slow. About 2011, 11% of trusts had some form of inpatient prescribing. After the last two tech funds, we're now at around about 35, 40%. And with the exemplar work, that will take us to just over 50%. So it's been a very long and slow journey in terms of rolling it out.
Okay, so these global digital exemplars are a pretty big part of.
Yeah, they'll really help us take the systems from some of the basic work that's already underway to really moving them forward to optimise the benefits that we'll see. So they're part of that onward journey to really take us from a basic level of prescribing to a much more advanced one.
Okay, cool. So that sounds like there's a lot of growth and investment going on. So how does that fit with the wider agenda in the NHS at the moment with Carter and cost pressure and those types of things?
So medicines expenditure within the NHS is approaching about 18, 19 billion pounds a year.
Yeah.
Of which the secondary care hospital element is approaching 8 to 9 billion pounds this year, of which we have very little visibility.
Right.
So Carter, of course, is looking at the efficiencies that we can gain through better information so that we can manage both the supply chain, but also we can look very much at focusing our clinical activities on medicines optimization. Without the information available to support those activities, we're going to struggle to actually deliver against the whole of that agenda. So e-prescribing is a real key part of that in terms of how we move forward to manage that wide agenda.
And so if I remember Carter correctly, there's something there about hospital pharmacy transformation programs, so that would fit within that element, would it?
Yeah, if we're going to transform the way that we deliver medicines optimization services, we need digital systems in place as a core to help us actually realise the benefits we can get in terms of focusing on individual patient therapy. Without that, we're not going to be able to focus on the 20% of patients that absolutely need human input, shall we say.
Yep.
We can't optimise and digitise systems. So yeah, it's key to the whole of the strategy around medicines optimisation, patient safety, and really starting to think about how we focus on managing our medicines bill more effectively.
So it does sound like electronic prescribing is very critical to a whole bunch of stuff.
Absolutely.
What role does analytics play in realising those benefits?
If we think about how we transform care, we need the information that's available to help us understand exactly how we're using medicines at the moment. We don't currently have much of that information. We have proxy information available from pharmacy stock control systems, we have point prevalence studies, and we have the long-winded way of manually collecting information. once we've got analytics at our fingertips that help us truly understand exactly how we're using our medicines, it will help us drive the quality improvements that we're looking for in terms of optimizing at an individual patient level, optimizing at a system level, and also starting to look really at the global patient safety challenge we've got around medication risk, which we're not managing terribly well at the moment as well. So key to all of that is really good in-depth understanding of exactly what it is we're doing, both in the prescribing and the administration arena within hospitals.
Cool. So that actually sounds quite scary when you say we don't really know how we're using medicines in hospitals. Luckily, I'm not in a hospital at the moment, but it does makes me a little nervous. So it sounds like there's a big safety agenda there as well. What's happening on that agenda at the moment?
So the World Health Organization has just launched the 3rd Global Patient Safety Challenge around medication error and reducing the incidence of medication error. And what we know when we start to look at the work that's coming out of some of the international research at the moment is that there are opportunities to reduce the risks of medication error that digital systems will help us with. But we don't fully understand exactly how that can be the case and how we can monitor and manage that without that information that we'll pull from the analytics systems. So if you think about very simple stuff around antimicrobial resistance and so on, having some really key indicators and markers of exactly how we're using these drugs will be key to helping us understand how we actually manage better the resource that we've currently got with those agents.
And we were talking about this yesterday, and you were showing me a really scary document with about 80 different
indicators,
things on it for patient. How does that fit with the context?
We know that there are a number of high-risk medicines that we poorly use and create very high-risk issues for patients. And we also know that there are around about 80 indicators that we can use to demonstrate how systems are reducing the risk and incidence of medication-related error. But to do that, what we need to do is report on those routinely and regularly to ensure both that we've optimized our systems to maximum benefit, but also that we're delivering the systems and services around them to deliver those benefits. So those 80 indicators form a core part of the sorts of things that with this sort of information we can start to track, analyse and improve systems as a result of it and patient outcomes following that.
And I think when we were talking about this yesterday, you were saying there's maybe about 20 of those that Triscribe could just do the regular tracking, reporting pretty much automatically.
So there are some very relatively simple ones that we currently can't track and trace that we could report on a regular basis and actually show how over time, when you start to change your systems, you can reduce the incidence of error for individual patients. Whether it's very relatively simple stuff around some of the anticoagulant use that we know at the moment is not brilliant, whether it's some of the incidence of poor prescribing around thromboprophylaxis. So there's some very simple things that we can do that will have very big impact in terms of patient outcome. Currently not possible without very long-winded manual paper collection.
So much easier, much faster.
It means we can put the basics in place and we can track what's going on and focus our efforts in areas that are likely to deliver longer-term benefit.
Fantastic. So I'm conscious that Anne's quite a scarce resource and people are interested in what she's got to say. Is there any questions from the audience? Anything else anyone would like to ask Anne while she's got the microphone? Normally she's quite difficult to shut up anyway. Yeah, cool.
I think it's potentially huge because if we've got a lot of automated reporting and analytics going on, we can understand exactly how we're using our resources. So one of the areas this looks at is medicines administration, for example. And of course, we know that medicines administration via any route other than the oral route tends to take more resource. So this very quickly shows us exactly where the parenterals need to be given, where the burden is, which means you can start to predict your workforce requirements and so on. Same thing with controlled drugs. So very different way of working because it really starts to pinpoint how you could effectively transform the way we work. Sorry.
Sorry, yeah, she's just asking how is that business change agenda being taken forwards?
So I think it varies in different hospitals. Clearly those organisations that have got the information available have started to think about some of this. Many of them, because they've not been able to see the information, it's just starting to dawn on them that they've got quite a powerful tool there that they can use to help think about transforming the way they work and putting a bit of disruption in the system, if you like. So there are a couple of organisations within the Exemplar group, for example, who've started to think about it. A couple of the organisations we've been working with to draw this together have looked at it and you could see the light bulb go off the minute they started to visualise what was there, quite quickly.
It's quite interesting. We do workshops with a range of clinical staff, and as soon as you start showing them the product, the first people that jump on it are nurses, and the first thing they are is, this is a learning tool, this is going to help professional development for me and my team, because I'll be able to really understand for a ward at a granular level how medicines are being used, who's doing what, why is someone we're looking at someone giving opiates intramuscularly the other day, well, why is that happening? And it just brings out these
that's
indicators.
A workforce example. One of the other things that quickly became apparent looking at the information is around certain groups of patients. So if we think about Parkinson's patients, and we know that if they have delayed doses, missed doses worse, but delayed doses, then of course we're likely to create problems for them. So just reporting on delayed doses for Parkinson's patients, we could immediately see the wards that needed a bit of help, maybe thinking about how they might improve what they were doing. So some very, very good ways of comparing, contrasting within an organisation, and a bit of competition within an organisation is never necessarily a bad thing. So yeah, that's been quite key as well.
Were there any other questions?
Okay.
Okay.
I forgot my name.
That's all right. So let me talk about, so all of that's great. Let me just talk a little bit about Triscribe the business. So this is a sales pitch bit, not the really clever bit. So where we are, I think I explained earlier, the founders are a combination of University of Edinburgh academics and Anne. So this company is actually a spin out from the University of Edinburgh. We are running a pilot program with 3 hospitals at the moment. So really going through in detail the process that Anne's just described, showing it to pharmacists, showing it to doctors, showing it to nurses, showing it to even to admin staff, explaining what it can do, and developing the data and visualization so that it's as close as possible to what those practitioners really need day to day. And the concept of that is to take the intelligence of world-leading academics around prescribing and administration practice and put that in the hands of frontline staff so that we get better medicines optimization, better safety, and a reduced reporting burden. It is early stage. The first commercial product will launch towards the end of the year when that pilot process is finished. I can't tell you what it's going to cost. I can tell you that it is a very light touch, highly secure, cloud-based IT system. It is not going to be a big, expensive product for people to use. And it's going to be driven around value. So, our job first is to prove that there's real value there before we start looking to see what the commercial benefit could be for the company and looking to see how we can realize measurable benefits into the NHS. And I think that's what we've got to say. I'd be happy to take any other questions, or I'm conscious that you all want to get home as well. So,
It's a good time to speak, isn't it? The end of the day,
end
on
of
the
the day.
final day.
Many people stayed awake for at least well done. And thank you, Anne. Thank you to everyone. And good. I hope you've enjoyed the event, and safe travels home. Thank you.